Hello, welcome to my channel. My students have requested me to explain the subtypes of von Willebrand, which to them is very confusing. So I thought I'll discuss von Willebrand disease as a whole in this video, but it is not a substitute for reading. Reading you will have to do, but with this basic knowledge, if you read, you will understand the subject better. Suppose there is an injury and there is a break in your endothelium. First is the vasoconstriction. Very small breaks it may be able to seal. Otherwise, there is a break in endothelium. Von Willebrand factor will bind to GP1B receptor of platelet. See, this von Willebrand factor is there within the endothelial cells. When it is injured, von Willebrand factor is expressed. So the platelet that is circulating now comes and binds to it. So that is how that binding happens. It is called adhesion. After adhesion, it should progress to platelet activation and then aggregation, and then the platelet plug forms. But in von Willebrand disease, it is only the adhesion that is defective. Does it mean that the aggregation will be normal? No. Why? Because unless adhesion occurs, it will not proceed to platelet activation and it will not cause platelet aggregation. So although the aggregation mechanism is okay, aggregation will not happen. So aggregation test also will be abnormal. The adhesion test is ristocetin adhesion test, that will be abnormal. And the platelet aggregation test, platelet aggregometry, that also will be abnormal. I think you got the point. It is not that there is something wrong with the platelet aggregation, but unless platelet adhesion occurs, it will not progress to platelet activation and platelet aggregation. That is why it is also abnormal in von Willebrand disease. I think it is clear. Now, I said von Willebrand factor will bind to GP1B receptor of platelet. And then what happens is this von Willebrand factor becomes multimers. So many molecules comes and becomes high molecular weight von Willebrand factor. What is the benefit? So many are there, so many platelet will come, and so it becomes a stronger adhesion. And a lot of platelets are there, so it gets activated, and the platelet granules will release whatever is inside. And what is there inside? You can refer to my video on platelet. The link I'll place in the comment region. So ristocetin adhesion test will be abnormal in von Willebrand disease. The same happens in Bernard-Soulier also, because there also the defect is platelet receptor GP1B. So the first function of von Willebrand factor we have already discussed, that is binding to platelet receptor. Now the second important function of von Willebrand factor is it binds to factor VIII and it transports factor VIII. So factor VIII travels along with von Willebrand factor. So in the absence of von Willebrand factor, the factor VIII will be destroyed or degraded rapidly. So in von Willebrand disease, although there is nothing abnormal with the factor VIII, since it is not having the carrier protein of von Willebrand factor, the factor VIII gets destroyed or degraded easily. So naturally, the factor VIII activity also will be low in case of von Willebrand disease. When this von Willebrand disease was discovered, say maybe about 100 years back, the concept was that you can treat it with factor VIII concentrate. Because 100 years back, the so-called factor VIII concentrate also were not very purified. So it always contained von Willebrand factor also. In modern times, we can use, say, for example, cryoprecipitate, fresh frozen plasma, etc., where you have both factor VIII and von Willebrand factor. Von Willebrand factor also is available for use in patients. And another drug that is used is desmopressin or DDAVP or the so-called arginine vasopressin. That is the antidiuretic hormone. What it does is it helps to increase the expression of von Willebrand factor from within the endothelial cells. Von Willebrand factor normally I said is present within the Weibel-Palade bodies, and these bodies are within the endothelium. And also, von Willebrand factor is present within the platelet because it is synthesized by megakaryocyte, and platelets are actually cut portions of megakaryocytes. So it also contains von Willebrand factor. This Weibel-Palade bodies, that is actually within the endothelium and not within the platelet. In this regard, what is given in the present edition of Nelson is possibly an error, because in basic medical subjects we have all learned that this Weibel-Palade bodies are there within the endothelium and not within the platelet. Within the platelet you have alpha granules, dense granule or delta granules, etc., not these bodies. What are the clinical features? Epistaxis, EC bruisability, menorrhagia, postpartum hemorrhage, etc. And the von Willebrand disease is the commonest coagulation disorder. Investigation, we said APTT will be prolonged because factor 8 travels along with von Willebrand factor. So if von Willebrand factor is not there, factor 8 will come down, at least the factor 8 activity will come down. So naturally, the intrinsic pathway will be affected and the APTT will be prolonged. Bleeding time again is prolonged. Why? Because I said platelet addition is not proper, so it will not progress to aggregation also. So you will have an increased bleeding time. Increased bleeding time with a normal platelet count. And whatever clinical or investigation that we are saying is basically applies to type 1 of our von Willebrand disease. Now coming to the request of my students, what are the subtypes? There are 3 types, type 1, type 2 and type 3, of which type 2 is divided again into 4 types. Okay. Now type 1, the clinical features that we have already said. Type 1, what happens is it is a matter of decrease in von Willebrand factor. When von Willebrand factor is decreased, you have a normal platelet count, but increased bleeding time, increased APTT, and that is type 1. And type 1, if you give DDAVP, more von Willebrand factor will be exposed, and so it will compensate for the decreased amount of von Willebrand factor that is present. So that is the treatment. Type 3 means von Willebrand factor is simply not there at all. So almost zero. There is nothing to bind and travel with factor 8. So factor 8 also comes down. So clinically it will behave just like a hemophilia A. I think it is clear, right? In type 1 we said von Willebrand factor is decreased. So there is some coagulation happening. And if you give DDAVP from endothelium, some of the von Willebrand factor will be expressed. So the absence or the decreased number of von Willebrand factor will be taken care of. Type 3 is autosomal recessive. There is practically no von Willebrand factor. So naturally, drastically reduced factor rate. So it behaves like a hemophilia A. Now the subtypes of type 2. Type 2 is also autosomal dominant. Type 2A means the von Willebrand factor is abnormal in the sense that multimers do not form much. When multimers are not there, not many platelet can bind. So whatever platelet plug that is being formed is weak. So hope it is clear. So in 2A, von Willebrand factor is a qualitative defect. It is not quantitative, qualitative defect. What is the qualitative defect? It will not form multimers to significant extent. So when multimers are not present, not enough platelet can bind to it. So clot becomes weak. So that is 2A. just too little multimers means you have von Willebrand disease. Just assume that there is too much of multimers. Then what happens? There will be a lot of coagulation within the system, within your vascular system, and a lot of platelet will get consumed, and that will get removed. So what happens? You have both thrombosis and thrombocytopenia. That is called thrombotic thrombocytopenia. That is in no way related to von Willebrand disease, because in von Willebrand disease, when the multimers are decreased, there is bleeding. But when multimers are increased, what happens? That is what I explained. So it is not part of your von Willebrand disease. Don't confuse. So 2A, I think, is clear. Now 2B is increased affinity of this qualitative defect is increased affinity of von Willebrand factor to the platelet receptor. So much so it will not leave it. So what happens? The body will remove this combination. Von Willebrand factor platelet combination gets removed. So then what happens? Von Willebrand factor will come down, platelet also will come. So in this situation, suppose you give DDAVP, what happens? More von Willebrand factor will be exposed from endothelial cell and more platelet will bind and you lose more of von Willebrand factor, more of platelet. So the point is 2B is the only von Willebrand disease where you should not give DDAVP. 2A means multimers, not found. 2B means too much affinity. It binds to platelet and just doesn't leave it, forcing the body to remove it. Okay, so there is thrombocytopenia plus decreased von Willebrand factor in 2B. In 2M, the qualitative defect of von Willebrand factor is it has got decreased affinity to platelet. If it is not binding to platelet, then how can the clot form? That is the problem with 2M. 2N means decreased affinity to bind to factor 8. So that means factor 8 comes down because this carrier protein is not there. So again, it behaves just like hemophilia again. Hope it is clear. 2M means both these things are affinity problems. 2M has got decreased affinity to platelet. 2N has got decreased affinity to factor 8. So hope it is clear. 2A means multimers are less. 2B means too much affinity to platelet. It will not release the platelet. Hope it is clear. In all except 2B, you can give DDAVP, but DDAVP classically is most effective in type 1 because the problem in type 1 is just decrease in quantity of von Willebrand factor. So by giving DDAVP, you can increase the quantity of von Willebrand factor by releasing it from endothelial cells. Type 1 is the commonest. So for that, this DDAVP is the drug of choice. 2A, I said this multimers are found less. So again, if you give DDAVP, more von Willebrand factor will be available. So a little more of multimers can form. So there also it is DDAVP still effective. 2B, don't give DDAVP. If you give DDAVP, more von Willebrand factor will be released, which is abnormal. It will bind to platelet and will not leave and forcing your body to remove it. So the decrease in platelet exacerbated by giving your DDAVP. So don't give DDAVP for type 2B. Can you give DDAVP in say type 2M and N? Actually, you can give. In type 2, M means decreased affinity for platelet. Type 2, N means decreased affinity for factor 8. Although decreased affinity, if you increase the number of von Willebrand factor with decreased affinity, again you will have some effect, no? So you can actually give DDAVP, but if it is not getting control, then you will have to give von Willebrand factor containing products like cryoprecipitate, like fresh frozen plasma, etc. Von Willebrand factor is also available for administration. So hope the subtypes are clear to my students. Now we can go and read your textbook.